Thank you, Deputy Jones. On the Murray case, Dr. Murray is present with counsel as previously indicated. The people by counsel as previously indicated. Dr. Steinberg, once again, is on the witness stand. All jurors and alternates are present as well. To everyone, good afternoon. To the jurors, good afternoon. Dr. Steinberg, good afternoon, sir. Do you acknowledge you are still under oath and still sworn to tell the truth?
Yes, sir.
Thank you. The resumption of cross-examination by the defense, Mr. Flanagan.
No further questions at this time, Your Honor.
Mr. Flanagan, thank you. Redirect examination by the people, Mr. Walgren.
Thank you, Your Honor.
Thank you.
Good afternoon, Doctor. Good afternoon. I just have a few follow-up questions. Mr. Flanagan had asked you if you knew whether or not Dr. Murray was ACLS certified, and you said you didn't know one way or another. Is that correct?
Yes, sir.
Did Dr. Murray act like someone that was ACLS certified in his care of Michael Jackson?
No.
Now, counsel also asked you about, or suggested maybe Dr. Murray was mistaken on the times. Maybe he was gone for as long as 10, 15, even 20 minutes. Doesn't that highlight the need for accurate medical records?
Absolutely.
Okay, to document the dosages, the time of the dosages, the vital signs, the condition of the patient at every important interval?
Yes.
Now, when you utilized propofol in New York, that was in a hospital setting?
Yes.
With all the monitoring equipment, things you've described here in court?
Yes, sir.
And when gastroenterologists and dentists and ER doctors get approval or through their societies, again, those approvals also dictate the need for all this monitoring equipment and that it be in the appropriate medical setting and things of that nature?
Yes, those societies dictate the appropriate training is necessary, appropriate monitoring equipment is also necessary.
All right.
And medical personnel to be accompanied to the doctor.
Okay. The sleep article that Mr. Flanagan brought up, you were familiar with that article before he brought it up to you?
Yes, sir.
And that did not say that propofol was an appropriate treatment for insomnia. It was simply an initial research article.
It was a research article that requires further study.
And in fact, in that was from 2010 out of China, correct?
2010, which is after 2009.
Thank you.
Thank you.
And it was first published in 2010.
Yes, sir.
And in that research article, patients were given propofol in a hospital setting.
Yes, in a hospital monitored setting. I think they specifically wrote down that the patients had the appropriate monitoring equipment.
And the study in China was approved by the Hospital Ethics Committee.
Yes, their IRB, their ethics committee had to approve it.
And what is an IRB?
It's a institutional review board. So anytime you do an experimental study, you can't just decide to do it. You have to get approval from an ethics committee. And they look over it and think if whether or not it's ethical and whether it's the right thing to do. And then once it's approved, then you can go ahead with the research trial.
And it was an experimental study.
This was an experimental study.
And they note that in their experimental study, they obtained written, informed consent from each of the subjects.
Yes, sir.
It was performed in a sleep disorders clinic run by a team of neurology and anesthesiologists.
Yes, sir.
They made certain that the subjects of the study fasted, in other words, did not eat prior to being administered propofol.
I think it was 8 hours.
8 hours of fasting.
Yes.
They were fully monitored, and specifically notes that they were placed in a room with blood pressure, electrocardiogram, and pulse oximeter, oxygen saturation, and each patient was constantly monitored during each treatment, correct?
Yes, sir.
The propofol was administered by use of an infusion pump to make sure there was precise dosing.
Yes, a regular drip was not used.
And there were no polypharmacy or multiple drugs were used, correct? It was just propofol.
Just propofol.
No other benzodiazepines?
Nope.
And in fact, this article, which was published in 2010, don't the authors of this article specifically state that further study still needs to be done?
Yes, sir.
In fact, on the last page of this article, they state, quote, future studies on the efficacy and safety of propofol-induced insomnia should be aimed at confirming these findings in a multi-center cohort study.
Yes, sir.
So the authors themselves acknowledge that it's only experimental at that time.
They say that specifically.
And it does not dictate an acceptable standard of care, correct?
No.
Correct?
I'm sorry. It does not dictate a standard of care.
Knowing that in 2010 this article was published and was characterized as experimental, isn't it in fact true what Dr. Murray was doing to Michael Jackson on June 25, 2009 in the months preceding was essentially an experiment?
Yes.
Dr. Steinberg, I want you to assume in this question that, again, the benzodiazepines that Dr. Murray admitted to giving, and I want you to assume that Dr. Murray gave just the 25 milligrams of propofol, okay? In that setting, with the benzodiazepines and the 25 milligrams, assume there was no drip, do all your opinions that you've shared with the jury here today still apply?
Yes. Still, it's inappropriate to give propofol for sleep. You don't give it in an unmonitored setting without the appropriate equipment or backup. You still need to be prepared for an emergency. His response to the arrest was still inappropriate, and his delay for 911 was still inappropriate, and his documentation was still inappropriate.
And it would be a foreseeable risk that the patient in that setting, with the drugs administered by Dr. Murray as he states he gave, it would be a foreseeable risk that the patient could suffer respiratory depression and cardiovascular failure.
Yes, sir.
And when you take all the extreme deviations in total that you've delineated, assuming it's the 25 milligrams, it's still your opinion that Dr. Murray played a direct causal role in the death of Michael Jackson.
Yes, sir.
Thank you. Thank you, Your Honor. Nothing further.
Mr. Logan, thank you. Recross-examination, Mr. Flanagan.
Doctor, on that sleep study that
Yes, sir.
we've commented on, the net effect was that propofol helped insomnia, didn't it?
Yes.
Oftentimes, doctors on occasion will use certain drugs for off-label purposes, won't they?
Yes, sir.
And sometimes the use of those drugs on off-label purposes become the norm in later years.
Yes, sir.
Now, in your analysis of this case for the medical board, you've made certain determinations of various acts of Dr. Murray were beyond the standard of care. Is that correct?
Yes.
Now, your analysis for the medical board is a lot different than the analysis in this case, isn't it?
Sustained.
In this case, you need to make an analysis as to whether or not each one of these deviations was a causative factor in the death of Michael Jackson, don't you?
Relevance.
Overruled.
I'm sorry, the question one more time.
In this case, you need to make an analysis as to whether or not these deviations were a causative factor in the death of Michael Jackson. Is that correct?
Correct. And I even in my statement, standard of care, I stated that it did directly impact his death.
Okay. Well, you've come up with a lot of deviations that you can feel that are egregious, that you've talked about in this case, that really had nothing to do with Michael Jackson's death. Isn't that correct?
No.
States the testimony.
Well, it didn't.
Just a moment, please. Overruled. The answer can remain.
I mean, not having a battery backup for monitoring equipment wasn't a causative factor, was it?
Again, when in this statement, I go through the standard of care. So even though the standard of care was breached, it may not directly affect in his it is death, but I comment on all the standard of care. But if you look generally on 5 of the 6 points I made, whether propofol should be given in the first place, was it given on a monitored setting, was he ready for an emergency, how he behaved during the arrest, and his delay in calling 911, those 5 things all directly linked to Mr. Jackson's death.
Dr. Murray gave propofol without problem for 40 days, didn't he?
Objection. Assumes facts, not in evidence.
The objection is sustained as to the form of the question.
You read his statement where he told the police that he'd been given propofol to Michael Jackson for approximately 40 days. 50 days? 40 or 50 days, correct?
Correct.
Without incident.
Correct.
Now, your analysis regarding the causation in this case, you've made certain assumptions, haven't you?
I don't understand your question.
Well, in concluding that a violation caused the death of Michael Jackson, you've made certain assumptions in this case, haven't you?
He got propofol, so you don't give propofol, so that's not an assumption. And then he was not monitored, so I didn't assume that. He wasn't prepared for an emergency. I didn't assume that. The way he described behavior on his very own words to the arrest, I didn't make that up. And his delay of calling 911 was not an assumption, it's fact. So I didn't assume anything. I have facts.
Well, you assume, for purposes of determining whether or not Dr. Murray was responsible for his death, that Dr. Murray gave the medications that were in Michael Jackson's body to him. Didn't you?
According to, it could be all from his body, yes. From Dr. Murray, yes.
You assumed that Dr. Murray gave him those medications, didn't you?
I can assume that it gave his medications, yes.
And you assume that he gave those medications in a lethal amount, don't you?
It can be assumed that he gave the lethal amount.
And as a matter of fact, you even
those are assumptions. You're right.
You've assumed that Dr. Murray gave him a drip along with the slow bolus injection, didn't you?
I believe he gave a drip, but just as I answered Mr. Walgren's question, when you give even 25 milligrams of propofol, and assuming he was on a drip, he would still be directly linked because the patient needs to be monitored even after 25 milligrams of propofol.
And you have no idea what 25 milligrams of propofol would do you?
I do very little, probably.
Nothing further.
Mr. Flanagan, thank you. We redirect by the people? People's counsel are conferring.
Just one question. Dr. Steinberg, just to be abundantly clear,
Sorry.
all the facts that were relayed to you in Dr. Murray's own words, and for the sake of argument, let's assume that all transpired and Michael Jackson then self-administered either lorazepam or propofol because he was not being monitored appropriately by his doctor who was entrusted with his care. Wouldn't Dr. Murray still be a direct causal link in Michael Jackson's death?
Yes.
Thank you.
Mr. Walgren, thank you. We recross, Mr. Flanagan? Thank you. May Dr. Steinberg be excused, Mr. Walgren?
Please, Your Honor.
Mr. Flanagan?
Yes, Your Honor.
Thank you. Dr. Steinberg, give me a moment. I want to thank you for your testimony. Please don't discuss your testimony or the facts of the case with any other witnesses until we finish the trial. You may step down and leave your excuse, sir. Thank you.
Thank you, sir.
You're welcome. At this time, the people may call their next witness.
Thank you, Your Honor. The people would call Dr. Nader Kamangar.
Sir, please remain standing and raise your right hand. Do you solemnly state that the testimony you may give in the cause now pending before this court shall be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Please be seated. Please state your name for the record. Spell your first and last names.
My name is Nader Kamangar. My first name is spelled Nader. Last name is spelled Kamangar.
Dr. Kamangar, good afternoon, sir.
Good afternoon.
Let me provide you with some introductory instructions, which are instructions I give to every witness in every case. The first of which is to please sit back and relax. The second of which is to speak in a loud voice, and that way everyone in the courtroom can hear you. The third instruction is to answer yes or no to a question that calls for a yes or no, rather than using slang like or which can be very tricky. And the last instruction is to wait until you hear an entire question before you even start to volunteer an answer. In our daily lives, many of us are used to interrupting each other because we think we know what's being asked, but it's important in a courtroom to wait for that full question to be asked in its entirety before you respond. Is that all okay?
Absolutely.
Thank you. Direct examination by the people. Mr. Walgan. You may.
Good afternoon, Doctor.
Good afternoon.
Sir, what do you do for a living?
I'm a pulmonary critical care and sleep medicine physician.
All right. And how long have you been a medical doctor?
Since 1996. 15 years now.
And where are you employed?
I'm employed at Olive UCLA Medical Center.
And can you describe for us, please, your general background, your education, and your training that led you to where you are in your career at this day?
Sure.
You want to make yourself a little comfortable so you don't have to bend over. You can actually move a chair if you want to.
Okay.
Sit up.
Just to give you a brief summary, I'm currently Associate Professor of Medicine at UCLA in the Division of Pulmonary and Critical Care. And I finished my latter part of my training with my fellowship in 2000 through 2003 at UCLA and at Cedars-Sinai Medical Centers in pulmonary critical care and sleep medicine. Thereafter, I assumed the role of assistant professor at UCLA, Olive Medical Center, where I've since been. Since that period, I've moved up to associate professor, and my practice involves primarily pulmonary critical care and sleep medicine, although I do spend some small periods of time doing general internal medicine as well. I am the fellowship program director for pulmonary critical care at our institution, as well as the associate program director for the larger multi-campus Cedars-Sinai program.
What are those two directorship positions?
These are for training programs for training doctors who've already finished their internal medicine residency to get further fellowship training or subspecialty training in the field that I belong to, which is pulmonary and critical care. I'm also a fellow of the American College of Physicians, the American College of Critical Care Medicine, College of Chest Physicians, as well as the American Academy of Sleep Medicine.
How about you have some involvement on a national or international level?
Correct. I'm part of the leadership of the American College of Chest Physicians as the vice chair of one of the committees that's responsible for really leading a lot of the programs involved on a national level with the American College of Chest Physicians. I serve as vice chair of that committee.
Okay, and can you please describe your educational background that, again, led you to these positions?
Right. So I started off my undergraduate at San Francisco State University, where I obtained a bachelor's in biology. completed graduate school, a year of graduate school at University of California, Berkeley. Went on to medical school at St. George's University in Grenada, and completed my internal medicine residency at Highland General Hospital, affiliated with University of California, San Francisco. Thereafter, I came to UCLA and Cedars-Sinai program for completion of my pulmonary critical care and sleep medicine training.
And can you describe for us, let me start with critical care medicine. What is critical care medicine?
Critical care medicine is the branch of medicine that really specializes in taking care of patients with diagnosing and treating patients with life-threatening diseases that often require sophisticated types of care, including sophisticated invasive monitoring, patients who need mechanical ventilation, who need to be on a respirator. But it also involves a whole host of disciplines. So we in the ICU care for patients with a variety of different problems that leads them to being severely ill. And our efforts are always to revive them, make them better, and get them through that difficult time.
What is, when you say invasive, was it invasive monitoring? Was that the word?
Right. Invasive monitoring can involve very basic things like having patients on continuous EKG monitoring their blood pressure, their heart rate, their oxygen saturations. But it can be more aggressive than that, and it can involve having patients on the ventilator who have respiratory failure, unable to breathe on their own, and can involve placement of a variety of different catheters to monitor what we call their intravascular pressures, to monitor the pressures inside their heart chambers, for example. Other procedures that are often done include things like putting in tubes in patients' chests to help relieve problems that resulted in them being on the ventilator to begin with, such as fluid accumulating in the space around the lungs or development of lung collapse. So it involves a whole host of disciplines. So as an intensivist, you not only have to be very familiar with cardiopulmonary physiology, so physiology that pertains to the lungs and the heart, but you really have to be comfortable with taking care of critically ill patients in general with a whole host of problems, with a whole host of organ failures.
And in the critical care unit, are these patients long-term patients in the critical care unit? Does it vary, or how would you describe that?
It can be variable. Now, where I practice is we have a younger population in general, patients that have had no access to health care and to insurance. So very often we have young individuals that have never seen a doctor or let their disease process progress, and they come to us. And because of age, often they have the capacity with our help to make it through, and sometimes the course can be short. But at times we have patients that require longer-term stay in the ICU, and one of the main reasons for that is patients require long-term need for a ventilator. But often over time, patients declare themselves. They either get better, or if they don't and everything else stabilizes, very often we can transition them by placing a tracheostomy, which is another one of the procedures we do in the ICU, and transition them to a lower level of care. So to answer your question, it's variable in terms of how long patients stay in the ICU, but in general, our goal is to try to get people out as soon as possible.
Thank you, Doctor. And now, you also specialize in pulmonary medicine.
That's correct.
And can you describe what that is for us, please?
Right. Pulmonary medicine deals with a variety of problems that affect the respiratory system, the lungs, and it can deal with problems that are pretty straightforward that we see in the community often, like asthma or emphysema, to a variety of different types of what we call interstitial lung diseases like pulmonary fibrosis or pulmonary hypertension. But it can involve a lot more in-depth diseases that most people may not be as familiar with. It ties in very well to critical care because in the intensive care unit, very often we do see patients that have respiratory problems, and the understanding of respiratory or pulmonary physiology is very essential, especially when we care for patients on the ventilator, because they go very hand in hand. But just to let you know, you can become an intensivist or a critical care specialist without the route of training that I did, which is through internal medicine. It can also be obtained through anesthesia. People that do anesthesiology training could go on and further subspecialize in doing critical care anesthesia, as can surgeons. So there's really 3 routes to becoming an intensivist. The route that I followed was doing internal medicine and doing a combined residency in pulmonary and fellowship, in pulmonary and critical care.
And do these fields, both critical care medicine and pulmonary medicine, require, because of the nature of the treatment, you to have knowledge in the field of sleep medicine?
Well, that is an optional thing, and there are those. There are actually programs now during the last 3 years that actually have there is a special training for people that have trained already in internal medicine to get further subspecialty training in sleep medicine. So it is actually a fellowship in and of itself. During the period that I trained, the sleep medicine was part of the 3 years of fellowship training that we completed, and we sat for. People like myself who were interested in the field took the boards and sat for the sleep medicine boards and practiced sleep medicine.
And again, if you could describe generally for us so we know about what you're speaking, what is sleep medicine?
Well, sleep medicine is rather new. It's been around for a while, but compared to other disciplines in medicine and other specialties, it's kind of new. But it deals with problems that relate to sleep. I think the public can all appreciate sleep apnea as the most common problem that we all hear about. People having problems with sleeping and their airway closing up because of the tissues relaxing during sleep. But that's really only the tip of the iceberg. And although it's very prevalent in sleep medicine, we also see a whole host of other disorders, from problems relating to insomnia to problems related to circadian rhythm problems, patients that have problems with the part of their brain that sets their sleep-wake cycles, to problems that result in seizures at night, parasomnias. There's a whole host of problems that we deal with in sleep medicine. But really, the ones that people are very familiar with is often things like obstructive sleep apnea or insomnia.
And are you, in fact, board certified in these fields you've mentioned?
Right. I'm quadruple boarded in internal medicine, pulmonary disease, critical care medicine, as well as sleep medicine.
Now, Dr. Kamangar, do you offer your services to the California Medical Board as an expert reviewer?
Right. I've done that for the past 2.5 years or so. I see that as a way of serving as a peer reviewer for my peers, to really maintain the level of care and professionalism, especially as it pertains to my fields of expertise within California.
And as a medical reviewer for the California Medical Board, did you conduct a review in this case involving the treatment offered by Dr. Conrad Murray to the decedent Michael Jackson?
That is correct. As a reviewer for the California Medical Board, often get contacted as to assessing a case and really giving an objective, unbiased opinion as to whether there's been any deviations from the standard of care in the management of a process that pertains of a patient that pertains to pertains to my specialty, basically.
Thank you. Before I get into that, as it relates to critical care, by the nature of critical care medicine that you've described, that involves the intensive care unit, the ICU?
That's correct.
And are there issues that arise as a result of the conditions or the conditions of the ICU that makes sleep medicine issues arise in that particular field?
That is very true. There's an inherent problem with sleep in the ICU. Patients that we see in the intensive care unit sometimes can be the extreme latter parts of their age. As we see patients get older, we're seeing more patients in the ICU with latter periods of their disease. And they naturally are more susceptible to the effects of just changes in the circadian rhythm.
Just let me stop you there, because you mentioned that earlier. What is the circadian rhythm?
Basically, there's a part of the brain that is responsible for secreting hormones such as melatonin that basically regulate when we're supposed to go to sleep and when we're supposed to wake up. And exposure to sunlight is a very critical element of that. And one of the therapies for problems related to that are daylight. And hopefully none of you will end up and be in an ICU or see an ICU, but just to give you a picture of what a classic ICU looks like, there are really no good-sized windows in most ICUs, and if there is, there's a slit at the very top. So patients that end up in the ICUs, one of the first things is that they lose that normal sleep-wake cycle. They lose that circadian kind of chronicity that they have, where they're used to waking up in the morning and being exposed to light and knowing the difference between day and night. That doesn't take much to throw some individuals that are more susceptible, like elderly individuals, particularly if they have an underlying problem like an infection or some underlying process that's led them to be in the ICU, to really develop problems with insomnia and sleep. And a major issue is the phenomenon called sundowning or delirium that occurs. And there are many contributing factors, too numerous to talk about here, but things such as pain, the underlying infections, the metabolic processes that are going on, and they all culminate and result in this problem and difficulty with sleep. And it can be often confounded with the delirium that exists in some of these patients as well.
Now, as far as the use of propofol, is that agent in the critical care unit?
Absolutely. We use it on a daily basis on multiple patients at a time in the intensive care unit.
And do you personally have specific training in regard to the administration of propofol?
Absolutely.
And could you describe that, please?
Well, our role is as intensivists or critical care doctors is slightly different than, for example, anesthesiologists that are another group that are obviously very well trained in use of propofol. The use of propofol in the intensive care unit from the perspective of a critical care physician is for induction of anesthesia when you want to place a artificial breathing tube, which is known as an endotracheal tube. So a patient that we feel can no longer breathe on their own, and modalities that we try to implement to try to kind of get them better have failed, such as a non-invasive modality. Sometimes we need to put a breathing tube in, and that requires giving them propofol in order to basically cause them to anesthetize them and sometimes deeply sedate them, as we call it, to allow for the placement of the endotracheal tube. We also sometimes add other agents when we're doing this in addition to the propofol, but it is the classic induction agent that we use. We also continue that drug very often. It's actually the most common drug that we use in the ICU for maintenance of sedation in a patient on a breathing machine. Now, different people tolerate a tube down their throat differently, but most people find it difficult, and particularly when you add an underlying disease process to that, say that they're having really difficulty getting oxygen to them, sometimes you really need to sedate them and make sure that they are compliant and synchronous with the ventilator, and we do that by using propofol.
So use it for a common use of it would be for use of an endotracheal tube to get that actually into the patient.
That's correct. That is in the auspices of where I use it as an intensivist, and I think I can speak for other intensivists. That is the most common use for induction, for placement of an endotracheal tube, but also for maintenance of sedation when a patient is in fact intubated, meaning has a breathing tube in, is connected to a ventilator.
And after putting in the endotracheal tube, that would then be connected to a mechanical ventilator that would be getting the oxygen to the patient.
Correct. Not just giving oxygen to the patient, but giving breaths, giving artificial breaths and helping them breathe.
And then what is your training in regard to your use of propofol at Olive View UCLA?
Basically, when you're using a drug like propofol, which is a very potent anesthetic, it's really important to be aware of the side effects and the potential risks that are associated with it, and to know how to deal with those. I think one of the first rules we use as intensivists is to be well prepared for any type of a complication, but when a problem does arise, and an emergency situation does arise, is to remain calm and be methodical about management. So preparation is key, and one of the things in preparation is to really be aware. What are the risks associated with that? Now, we deal with a kind of a unique patient population because they tend to come to the ICU because they have some issue or some major problem, life-threatening problem that leads them to the ICU. So we're even more cautious. I can tell you, I don't use propofol as an induction agent in all my patients that I place on a ventilator. And the reason for that is some of these patients are unstable. As we're monitoring them continuously with blood pressure, heart rate, if I have a patient who is already sick, who has an infection, for example, who has hypovolemia, low circulating blood volume, and I see that their blood pressure is tenuous, meaning it's unstable, I actually don't use propofol as an induction agent. I tend to use another agent that tends to have a lesser effect on blood pressure, because propofol can have, particularly when it's used as a bolus, can have a pretty profound effect on blood pressure, particularly if you're dealing with other elements such as underlying volume status, the patient that is, has low circulating blood volume or who is infected. So that is very, very important to recognize.
And when it's being used as a deep sedation, does that require ACLS certification or training?
Absolutely. When we're actually since we're a training program, even if we have residents who are training in internal medicine, we have to supervise them doing it. Even our fellows who I supervise, who are getting subspecialty training in the field of critical care and pulmonary disease, we still have to supervise them placing endotracheal tubes in the ICU, certainly after they've met criteria for having done enough of that procedure and have met criteria for deep sedation. There are tests that people have to take, then they're actually able to use it to induce patients. But we're very careful using it, and it's really restricted to either us as the intensive care specialists, or if we're not around, anesthesiologists are always there overnight in the hospital. The residents actually have to call anesthesia for doing that procedure.
And would someone then administering it also have, I guess as part of ACLS training, have airway management skills and training?
Absolutely. Airway management is really fundamental. Well, for the purpose that we're talking about here is that we're often using it is to induce anesthesia, to put a breathing tube in. You wouldn't be giving it if you didn't know how to actually put an artificial tube in. So you know how to use a laryngoscope, which is a device that you use to actually lift the tongue and look at the back of the throat and be able to see the vocal cords in the airway and place the tube in. So that is correct. But even in other circumstances that the drug is used, it is always necessary to have somebody that is comfortable and confident in maintenance of an airway and should be able to respond to the physiological consequences that may occur with the use of this drug and be able to reverse it.
How about the need to be able to recognize impairment or recognize where the patient is on the continuum of sedation?
Right. The continuum sedation, I think, is an area that's big for us as well as anesthesia. And basically, there's a really fine line between patients that go from really what we call moderate sedation, where they are still responsive to verbal stimuli. When you're calling them, they're sleepy, they're in a dreamlike state, but they're able to verbalize, respond to verbal stimuli, to going into actually 2 steps further, meaning to deep sedation and then beyond to general anesthesia. There's a fine line, and that is referred to as the continuum with sedation. So in some patients, particularly that are predisposed because of underlying illnesses and issues, it sometimes is very hard to predict when one goes from being in moderate sedation and then falling into really a state of what we call general anesthesia, where they're not even responsive to painful stimulation. So that can often happen. And we in the intensive care unit are very, very, very serious about this. There are sedation levels of sedation that nurses have to follow when we actually even leave our patients on a drip on propofol, to make sure that there is not an accumulation of the drug, so that you're not giving too much of it. So it's important for there to be this titration or a lowering of the drug as necessary, depending on the level of sedation that one achieves, one is desiring to achieve. And normally, we always want to have the least amount of sedation to be able to do what it is that we're doing.
Now, in your practice in the critical care unit, when propofol is utilized, who is present as far as medical professionals?
When propofol is utilized for induction, yes, that's because that's an important question versus maintenance. For induction, there has to be either an intensivist, an ICU specialist such as myself, or an anesthesiologist present. Those are very, very, very strict rules. Now, there are hospitals that may not have an anesthesiologist overnight, for example, and I do understand that this is still in the community where people still have emergency room specialists or ER doctors, but they too are very comfortable and confident in the management of the airway and complications that can arise from the use of a deep sedative such as propofol.
All right. And present then would be, you have a nurse on hand?
Right. A nurse is always present, and actually when we are using this drug in the intensive care unit to anesthetize a patient, to prepare them for putting placement of a breathing tube, we actually have the nurse pushing the drug, monitoring the vital signs, which are the heart rate, the blood pressure, the respiratory rate, the oxygen saturation, continuously at that time. Absolutely. We're never alone.
Okay. And you would also have probably a respiratory therapist?
A respiratory therapist is always in hand when the decision is made to put in a breathing tube. The only caveat being sometimes things can occur in an emergency in the intensive care unit, and you do what you do and you just call for help or call what we call a code blue. And that may be the only exception where some of the people, like a respiratory care specialist, may not have time to make it there. But with that exception in mind, they're always present.
And you just touched on it briefly, I believe, but in your practice, again, in the critical care unit, the required monitoring equipment is what?
The required monitoring equipment is a continuous EKG or electrocardiogram monitor, where we're not only seeing the heart rate, but we're actually seeing the waveform or the pattern of the heartbeat to make sure that not only are we monitoring the actual rate, whether it's too high or too low, but to look for irregularities or arrhythmias or abnormalities in what we call the QRS complex, the heart rhythm. So that's being monitored continuously. We're monitoring blood pressure continuously, and most would agree depending on the severity of the illness, we're monitoring every 2 to 3 minutes. We're monitoring the pulse oximeter, which is the oxygen saturation that is measured via a probe attached to the finger, and that is also usually has a pulse where you can actually hear, if you dial it up, you can actually hear that beeping sound that actually tells you sometimes that the oxygen level is getting too low, and alarms as well when there's a precipitous drop or there's significant drop based on where the alarms are actually set when there's a drop in the oxygen saturation. And on our patients who are on mechanical ventilator, who are on a breathing machine, we also have a capnometer, which is a device that's attached to the end of the breathing tube that measures the amount of carbon dioxide that is exhaled at the end of each breath. And that is also very, very helpful because it really tells us when a problem occurs and allows us to avert a problem before the oxygen levels get affected, meaning before the pulse oximeter goes down, meaning if a patient stops breathing for some reason. Now, on a ventilator, you're usually assured that they're getting a breath if you're on a mode of a breathing where the ventilator is supposed to give you a certain number of breaths. But at times, the tube can get obstructed, and the first thing we always usually see is that capnometer, that end-tidal CO2 monitor, shows that the carbon dioxide levels are changing and going up, and the respiratory pattern is changing.
Thank you, Doctor. Now, going then specifically to review in this case involving decedent Michael Jackson, you found multiple extreme deviations in the standard of care. Is that accurate?
That's correct.
And in your report, you went through noting multiple extreme deviations and then followed that with a specific analysis regarding the care given as it relates to insomnia. Is that right?
That's correct.
I want to begin with the deviations you found prior to getting into insomnia. First, you noted that the setting where Dr. Murray was providing the propofol was unacceptable and was an egregious violation of the standard of care. Is that accurate?
That's correct.
Yeah, please
what I was
explain
referring to was using this drug in a setting outside of a highly monitored set unit or a highly monitored facility, meaning intensive care or an operating room or a surgical center with very strict monitoring capabilities. It really, to someone in my field, to really even conceive of using this drug, a deep sedative, in any place outside those that I mentioned is really inconceivable.
Inconceivable?
Right.
You also discussed the need for the doctor to be highly skilled in airway management and advanced cardiac life support. And in this particular case, found that Murray's treatment was, again, an extreme violation of the standard of care?
That's correct.
Could you explain that, please?
Yeah, I think we went over some of this earlier, but it's really important when you are using an agent such as a deep sedative like propofol that has potential of causing deep sedation and further continuum to general anesthesia, to be able to deal with the physiological consequences that can occur. And what are those? Well, we've talked about the lowering of blood pressure that can occur with the use of this drug, often can be compounded by other medications or problems that patients may have. The stoppage of breathing, which is called hypoventilation, which is a diminishment in the rate of breathing, and then finally apnea, which is a cessation of breathing, can occur due to this drug. So one has to be able to deal with those consequences. And ACLS, which is really basic advanced cardiac life support, really is essential to being able to deal with some of those potential complications. And airway management allows one to be able to deal with the airway complications that are very, very common. And one thing I didn't mention is, other than the hypoventilation, the lack of breathing, and the diminishment in respiratory drive, the ability to breathe, is obstruction of the airway that can occur. And some patients are more predisposed to that than others, particularly those that have sleep apnea, for example, where the tongue, where you lose that tone, muscle tone, with the use of this medication, and the tongue flops back and the airway obstructs. So there has to be an understanding of how to manage from very basic airway issues, such as extending the head, thrusting the jaw forward, or chin lift, to being able to establish somewhat of an artificial airway, to delivering more oxygen, to finally being able to provide an artificial airway, meaning placing a breathing tube, and being able to deal with that if that was to become necessary.
And can you describe, I know with your hands you made a motion of tilting the head back and doing a chin lift. Can you describe what those two things are?
Yeah, those are very basics to really being able to really secure the airway and eliminate the possibility of the upper airway obstructing, meaning the tongue flopping back and the airway closing up as a result of the tissues in the back of the throat. So by basically extending the head and pulling the jaw forward, you actually increase that space that is in the back of the throat. We see this all the time when we use some other sedatives, when we do procedures like bronchoscopies, where we use drugs like Versed and fentanyl. We see that suddenly patients, their breathing slows down and their oxygen saturation goes up, and really doing that jaw thrust really helps really open up that space in the back of their throat and allows them to ventilate, and allows that effect of that medicine to wear off, and the level of sedation to be less deep than what was anticipated. So there always should be preparedness when you're using, for example, moderate sedation, that the patient may go into deep sedation and even to general anesthesia. And certainly if you're using deep sedation, you should be well prepared to deal with the possibility of someone going into a state of general anesthesia.
And the chin lift that you indicated, is that part of the same
technique?
Right.
Chin lift and jaw thrust really, I think, are go hand in hand, but jaw thrust is really is critical in terms of helping reduce the obstruction in the back of the throat.
You also talked about the need to have to always have the presence of additional bedside nursing assistants, and the lack of such assistance you found to be an extreme deviation. Is that correct?
Well, the setting where I understand that, for example, anesthesiologists use propofol for what's called MAC.
And that's monitored
anesthesia care. I apologize.
Just a moment, please.
Yes.
We're talking over each other. Let's wait for one speaker before we respond or ask another question.
Sure.
You mentioned MAC, and
right. In those scenarios, it's when it's used, it's very important to have a nurse at the same time at the bedside. Now, as I explained earlier, there are times in critical care medicine where emergencies happen in the hospital, where we respond to somebody that had stopped breathing, and it's an unforeseen event that occurred because somebody had an acute heart attack who was there in the hospital for another reason. And in those scenarios, we may not have a nurse present, but normally in the intensive care unit, we always have a nurse present. They're actually part of the care of being in the ICU is having more vigilant, sometimes one-to-one nursing coverage, meaning one nurse to one patient, so they are really able to deal with all the complexities and all the different things that they have to do and really pay good attention to that one patient who's critically ill.
Thank you. Now, but in this case, you comment on the need for Dr. Murray to have needed to have additional bedside assistance, and the lack of it was an extreme violation.
I think in this scenario, clearly it would have been helpful and would have provided that additional support, somebody that was providing the anesthesia, providing the sedation, and somebody that was actually able to monitor. So it allows you to really be able to not do two things at once, to really be able to pay complete and utter full attention to our patients. I think,
And of course,
yeah.
of course, it's absolutely essential if you're going to be a doctor that's going to leave the patient and leave the room, correct?
That's obviously without saying that. That is clear. That is really the really fundamental basics of the Hippocratic Oath, or kind of the ethics and morals that physicians swear by. Is first rule is to do what's right for your patient, not to abandon your patient. Absolutely.
Not to what?
Abandon your patient.
Now, you also mentioned pre-procedure setup. And again, as it relates to this particular case and the facts you've reviewed as it relates to Murray's treatment of Mr. Jackson, what did you conclude regarding pre-procedure setup?
Right. There are really some basics that need to, like I said earlier, in critical care medicine, I'm sure anesthesiologists would agree, it's always imperative to be prepared and be able to deal with the challenges and unforeseen circumstances that may arise. And that is part of that, is being prepared when you are using a drug that can potentially have untoward effects. And it's very hard to predict what those effects are. It is even more so important to make sure that you have certain capabilities. You have continuous heart monitoring, continuous EKG monitoring. You're able to have a non-invasive blood pressure device that measures blood pressure at least I would say every 5 minutes, to really show where your patient is going. I mean, we know in these situations patients are dynamic, meaning things are changing every second, especially when you're giving them medications. And just because they look good at 1 minute doesn't mean at the next minute they're going to look equally good. So blood pressure monitoring, heart rate monitoring with a continuous EKG, pulse oximetry to have that measurement of the arterial oxygen saturation with audible pulse, as well as alarms that tell you if the saturations are coming down. Apparatus that allows you to protect the airway. One of the other untowards complications of sedation can be aspiration, where patients basically regurgitate contents in their stomach into their lungs. And that could be very, very dire. And once the airway, the breathing tubes, fill up with whatever it is that was in the stomach, you sometimes are not able to ventilate them. You're unable to deliver oxygen and move carbon dioxide, and patients can die. So it's very important to be prepared for aspiration. So you need to have a suction catheter. Suction catheter in the hospital is very easy because there are devices connected to the wall, and you connect the suction catheter, and you're able to, when you're doing that procedure or you're giving sedation, to suction the mouth, the oral cavity. But certainly if you're away from the intensive care unit, for example, in a procedural suite, you can have portable devices that apply suction and be able to suction the oral cavity in case there were secretions or gastric contents from the stomach that are regurgitated upwards. And a crash cart, the capabilities to deal with some untoward circumstances such as the heart stopping, to have medications on hand like adrenaline that basically stimulates the heart to beat, and medications to reverse the blood pressure lowering effects of some of these agents like ephedrine or neosynephrine, medications to deal with some of the fast or slow heartbeats that also can occur in conditions where patients become unstable. And then the other would be an automated defibrillator, a device that can shock patients. And that is really more applicable when patients have abnormal heart rates, particularly what we call ventricular arrhythmias, when their heart rate is such that their heart is unable to pump appropriately, and where we use those that device to shock their heart out of that abnormal rhythm. So that is another component that needs to be present.
And how about
Excuse me. Let's all try to speak just a little bit slower. I know Mrs. Theodoro says it's fine, but I think we need to just slow up. Thanks.
Thank you, Your Honor.
I apologize.
How about an infusion pump? Is that?
Absolutely. If you're using propofol,
You're speeding up.
if you're using propofol, it is imperative to have a precise method of delivering the drug as a drip. It is very hard without that to know exactly how much is being infused into a patient. So having an automated pump, infusion pump, is very key. Our nurses are very familiar with it because we never have anyone who is on sedation, even with a breathing tube in, which is protecting their airway, that is not connected to a pump. And remember that these are people that actually have a breathing tube already in them. So it's imperative to have an infusion pump, which allows you to really precisely know how much of the sedative you're giving.
And doctor, you concluded in your analysis of the care Dr. Murray gave to Michael Jackson that the lack of this equipment, including the cardiac monitor, the blood pressure cuff, pulse oximetry with an alarm, suction, the crash cart, the airway equipment, the lack of all that equipment and the skills to use it represented, again, another extreme departure from the standard of care?
That's correct.
And when you're using these extreme departures in your vocabulary, in your analysis, does that equate to gross negligence on the part of the doctor?
Correct. I think once you kind of violate the standard of care, these terms you use, really the way I look at it as someone that's not in the legal world, is how far you go from that standard of care, the degree of which you deviate. And certainly extreme is when this is just something that we just would never expect to see in a similar circumstance being practiced by some prudent physician in a reasonable, in a similar circumstance.
And have you ever seen, in your personal experience, a doctor administering propofol to someone at home in the setting we've been describing?
No, this was the first time I've heard of that.
And when you conclude, as you have on these and as we go forward, that it's an extreme departure, you're concluding that you would never expect to see that from a reasonable, prudent doctor.
That's correct.
You go on to talk about the lack of medical records or charting, and you found that to be an extreme violation or gross negligence. Can you describe that and your reasoning?
Right. When patients come in for a procedure for sedation or even to the intensive care unit, one of the first things we need to do is have a basic history and physical exam on them, to know what their history is, what are their risks, what are underlying issues that they may have. That automatically allows the people caring for that patient to really use precautions and judgment. Again, it's all about being prepared, and have vital signs, just the initial vital signs. Well, what was their blood pressure, heart rate before they got any medications? So that's part of the charting. But also, once you do initiate any kind of therapy or sedation, whether it's in the ICU or outside of the ICU, such as a procedure suite where people do endoscopies, bronchoscopies, colonoscopies, it is important to chart just as often as you're looking at the vital signs and looking at the heart, measuring the blood pressure and looking at the heart rate and oxygen saturations. You're actually writing these. And the reason this is important is sometimes trends in medicine are very helpful. As doing critical care, you kind of learn to be an investigator, and you kind of look at trends, even though at that moment things may be good. But if you see that the blood pressure, just 5 minutes ago was 180 over 100, and next minute it's 100 over 60. Even though 160 is probably, that's what my blood pressure runs, that is still alarming. That suggests a trend. And by following charting, you can actually open your eyes to trends and have things that can occur that are unexpected and prevent a catastrophic complication before it happens.
You next discuss the need for continuous and vigilant observation of the status of the patient during sedation. And in this case, you found this to be an egregious violation, referring to it as abandonment of the patient. Can you describe your findings and your rationale in that regard?
Right. Like we mentioned earlier, it's imperative for the physician to be observing the patient at all times. I mean, this is the very basics of medicine, is really putting your patient first. And in this case, it was clear that there was a period of time when Mr. Jackson was basically left alone and was not being monitored. And that in somebody that is receiving sedation is really not acceptable, and that's why I felt that was an extreme violation of the standard of care.
And why is that continuous visual monitoring so essential?
Right. I think it is even more imperative in circumstances where some of those more advanced capabilities and eyes are not on the patient. For example, if you're not in the ICU and you're not have all those advanced devices, I mentioned capnometer, that device that measures the exhaled carbon dioxide, which can sometimes detect a problem before the oxygen levels decline. It's even more so important to actually monitor the patient, to actually be looking at the chest rising, to be seeing if the airway is obstructing. You can sometimes look for, actually you can always be able to look for the chest rising when the patient breathes in. And sometimes when the airway obstructs, there may be a paradoxical movement between the chest and the stomach, and that tells you that the patient is having difficulty breathing. So it's really imperative to be constantly observing these patients. And again, I'm referring to a situation where you do not have an artificial airway, just to be clear, because in the intensive care unit we have patients on a ventilator, and although there's a nurse, they may not be looking at them all the time, but they have a machine breathing for them.
And they're hooked up to all the monitoring equipment.
That's correct.
Now, you also touched on the concurrent administration of both the benzodiazepines in this case and the propofol that Dr. Murray admits to in his statement. And you commented on this concurrent administration you found to be an extreme violation in the standard of care, correct?
That's correct.
And can you please explain that?
Yeah, there's, as we talked about earlier, the continuum of sedation, and that there's a very fine line between going from moderate sedation to a state of general anesthesia, and that it's very unpredictable, how that can happen. That is even more so an issue when you compound different agents and you use them synergistically, meaning the effect of both of them together is higher than the effect of each of them individually, and that's really synergy means. And using benzodiazepines such as Ativan and Versed or Midazolam and lorazepam, in addition to propofol, can often have that synergistic effect and have even a greater effect than one would have expected with either individually.
So it could result in a more pronounced decrease in blood pressure?
More pronounced decrease in blood pressure, but also a more significant depression of breathing, or a respiratory depression that can cause an absence of ventilation or apnea or cessation of breathing altogether.
And decreased cardiac output as a result, or
right? Those actually sometimes go very much hand in hand. You can have the effects that of the dilation of the blood vessels in the periphery as a result of these agents, particularly propofol, which really is known to do that, called venodilation or vasodilation. But you can also, by causing profound respiratory suppression and lowering of the oxygen levels, once there is very low oxygen perfused to the heart actually stops because of the underlying respiratory impairment or the lack of breathing. So what I'm saying is that the heart stoppage can occur, or the cardiac arrest can occur either from the medication's effects directly by causing low blood pressure, but also probably just as commonly occur because the medications together can have such a profound effect on the ability to breathe that the lack of breathing results in that lowering of the oxygen levels, and that the vital organs, particularly the heart and the brain, don't really like and result in really cardiac arrest.
And staying on this topic of the concurrent administration of both the benzodiazepines as well as the propofol, you specifically commented on the fact that Dr. Murray noted that Michael was dehydrated. What significance did dehydration play in possibly having a more profound effect on this concurrent administration?
Right. As I was earlier talking about my profession and patients we see in the intensive care unit that often have confounding issues, well, this is one of those issues. This just happened to be someone that was not in a hospital. But to be dehydrated basically means that your intravascular volume, the blood circulating is limited. The plasma that's circulating is limited because of losses and lack of replenishment, and that in itself can cause in some individuals a lowering of blood pressure. Now, to add to that, the additive effects of two separate sedatives, that can be another effect that kind of culminates in this perfect storm that occurred here that resulted in Mr. Jackson's death.
And you found this concurrent administration of the benzodiazepines and propofol, particularly in light of Dr. Murray's knowledge of the dehydration, to be, again, another extreme deviation or act of gross negligence?
Right. I think it's really critical to assess your patients. Every patient is different, and if you feel that a patient has risks, I mean, I gave the example of even in the intensive care unit, when we do use propofol, if I have a patient whose blood pressure is to begin with somewhat lowish, even if I do decide to use it, I have them on intravenous fluids, wide open, resuscitating them actively because I know what's going to happen next if I use propofol. In addition to that, certainly putting patients on positive pressure ventilation, which is on a ventilator, that in addition to that will have another blood pressure lowering effect. So it's very important to be aware of the patient, the underlying physiology, and do things that kind of prevent these unforeseen, disastrous issues. So really, these things you should always anticipate the worst, and really your patient's history, what they are like at that moment when things are still okay, really ties into that pretty greatly.
Mr. Walken, at a convenient time, let me know for the mid-afternoon break.
Okay, just a couple more points, Your Honor. Again, we're still talking. We haven't gotten into insomnia yet and the sleep medicine. But before we get there, you spoke about the failure to call 911, and you called that an extreme and unconscionable violation of the standard of care. Please explain that finding.
Right. When a patient is found out of the hospital in cardiopulmonary arrest, And one does not have the capabilities to deal with that, meaning the apparatus that we've so discussed. The first rule of thumb in basic life support is to call for help. Now, if you have someone present next to you, you tell them to call for help. But if you have nobody, the most important thing is call for help. Get the people there that have the tools and the means to really be able to help your patient. Once they've been called, obviously the efforts to perform CPR are imperative, but it's really critical to call 911 as soon as possible.
And you go on to talk about Murray's ineffective and improper CPR, and you found this to be a serious violation of standard of care. Can you describe that?
Right. What I found here were two things. First of all, when Mr. Jackson was first found, he was noted to have a very thready pulse at a beat of 122 beats a minute. And the main thing was that he was not responsive, not breathing. So the most important thing at that point, if in fact there was a pulse, was to actually deal with the breathing issue and the ventilation, the ability to move air. Certainly for a non-medical professional, if you find someone unresponsive, the most important thing is doing actually CPR. But this is slightly a different take on that, just because we were dealing with a medical professional. The fact that CPR was performed on any surface other than a hard surface, meaning the floor or a backboard, is really provides for ineffective chest compression. By doing CPR, one of the most important things is to be able to compress the chest using two hands at the center of the chest. Imagine drawing a line between the nipples with two hands over the center of the chest, with standing over the patient where you actually are able to use some force and allowing the blood to circulate. Doing it on anything other than a hard surface really robs from that effectiveness of CPR and does not allow for that effective circulation. Furthermore, doing it with one hand on the front of the patient, one hand on the back, is really very difficult to imagine how you could effectively provide for that, in particular on a surface other than a hard surface. The thing I would add is to even if CPR, chest compressions, are performed, even in the best of circumstances, doing everything right, you're really circulating blood at 20% or so of its normal capacity. Now, if you violate any of these rules, the surface where the patient is on, the technique that's used, you're really even eliminating that number significantly. And sometimes by doing ineffective CPR, you're really actually, it's really is a disservice because it's not allowing for really what you're trying to accomplish. And unfortunately, CPR technique is one that even some, many folks that even go through training are still not very comfortable with and don't always do appropriately.
I need to take the break, Mr. Lovett.
Okay.
Ladies and gentlemen, we're going to take the mid-afternoon break. As always, please remember both the written and the verbal admonishments and orders. We'll take a break until 10 minutes after the hour, at which time we'll buzz out. So we'll see you at 3:10 p.m. Thank you.